Hello, everyone, and welcome to another episode of the Overcoming Chronic Illness podcast. My name is Dr. Brian Rade, and I'm a naturopathic doctor. And today I am very excited to be joined by a fellow naturopathic doctor, Dr. Carissa Doherty. Dr. Doherty practices in Burlington, Ontario, here in beautiful Canada. And Dr. Doherty, along with her sister, Sonia Doherty, they are just wonderful, brilliant, cutting edge naturopathic doctors. Can't say enough good things about them. I've heard them lecture a number of times on topics on complex chronic illness and topics very much related to complex chronic illness. And I'm just really looking forward to picking Dr. Doherty's brain today. In a couple of months, I'm going to be interviewing Sonia, so have multiple Dr. Doherty's on the podcast soon. But I am, yeah, really looking forward to just talking complex chronic illness and seeing what's on her mind. She's always trailblazing, thinking of or looking into new therapies, trying different things with her patients and whatnot. So I'm just going to have a general chat about complex chronic illness with her today, and I'm really looking forward to it. Anyone who's watching this on the YouTube channel may notice that you can't see me right now. Those of you on the listening to the podcast wouldn't know the difference, obviously. But if you're watching the video version of this, like where's Dr. Rade? Where am I? I have my video turned off. Unfortunately, I'm just fighting off a little bit of a cold. Might be able to hear that in my voice a bit, and I'm just not really camera ready today. So I'm sure Dr. Doherty, when I bring her into the meeting here, the Zoom meeting, then she'll be on camera. So you have someone to look at, but I'm going to be a blank screen today. So I am going to pause the recording and I'll be back in just one moment with Dr. Doherty. All right, everyone, welcome back. And I am now joined by Dr. Carissa Doherty. Dr. Doherty, thank you so much for joining me today.
Thank you. It's nice to be here. Thank you.
It's a pleasure to have you. We've just been having a nice 15-minute chat prior to this. Like, all right, we should probably record a podcast now. So yeah, it's just nice to have, yeah, really nice to chat with you. Dr. Doherty, just before we jump into some of the questions I have here, would you mind just telling listeners about just, who you are, where you practice, and how you got into this wild, wacky world of complex chronic illness?
Sure. My name is Carissa Doherty. I'm a naturopathic doctor in Burlington, Ontario. It's about 20, well, it depends on traffic, but 20 to 40 minutes away from Toronto. So I live in the burbs and I practice with my sister, Sonia Doherty. We actually have two other naturopaths, which is great. Danielle O'Connor has been practicing with us for like 20 years, and we have a new grad, Rachel Onai, who's brand new, which is kind of nice. You forget what you don't know when you have a new grad asking all these questions. You're like, how did you know that? I'm like, I don't know. I don't remember. And so in our practice, it's kind of small. We're in a little mini mall. The liquor store is across the street, and the beer store and the hardware store. So we live in sort of this nice little neighborhood where I live 5 minutes that way. My sister lives 5 minutes that way. And we get a chance to have our kids drop by the clinic often. We have sort of this nice place where we have lovely staff we've had for a couple of years. And I see more chronic issues. So I see more complicated cases, things like Lyme and mold and tricky cases. I'm currently obsessed with POTS, POTS, postural orthostatic tachycardia syndrome. But I guess when I was a kid, I was actually quite sick. So at age 5, something happened and I became blind and I lost balance. So sudden onset in Toronto when I was a kid, I was actually born close to where the school is, the naturopathic school is. So my sister and I were born in Toronto by where we got trained as naturopaths. And I went blind and I couldn't stand up one day. So my parents immediately took me to Sick Kids downtown Toronto, the best children's hospital, maybe in Canada for sure. And I had doctors fly in from all the world, and they said I either had a tumor in the fourth ventricle or AIDS, because AIDS was very popular at that time. It was new and it was just sort of being developed, which is pretty shocking. So they gave me massive doses of corticosteroids, and my vision came back, and I had a spinal tap, and I had all these crazy experiences. I was in the hospital for about a month, and the doctors were great. I do think they saved me. I really appreciate all the work they did. But even as a young kid, I felt like the why was always never really addressed. And so fast forward a couple of years, I did recover quite well. I just was never kind of back to where I was. Like my vision was off, my athleticism was off. And then I became sick when I was kind of an early teenager, more fibromyalgia, chronic fatigue, constant stomach aches, constant headaches. And I went to see my first naturopath. So he explained what he actually was a medical doctor in India and then trained as a naturopath. And he went through what his training was and it just clicked. I'm like, I'm going to be a naturopath. He's like, okay, it's the first visit. Do you want to know what I'm doing or what I'm going to do? I'm like, no, I'm good. I love it. I think it's great. I think you're working on the root cause. And at this point, I was like 15, 16, maybe even younger. And he said, okay. I'm like, how do I do it? So he told me what to take in high school, what courses to take, how to like, what to take, maybe what to take it, not exactly, but to take some sciences in university. And then he like, pointed to his degree and he said, that's where I got my degree. That's the only place in Canada right now. Um, did you want me to do something for your care? And I'm like, yes, sounds great. Um, so I committed kind of early to be a naturopath. And it's funny because my sister thought I claimed it. And so we had a friend who was a naturopathic student. I was like in first year, she was in second year, and she actually worked with my sister at a restaurant. So she pulled my sister aside, Sonia, and said, you can be a naturopath too. And my sister's like, no, Carissa's going to be a naturopath. And the woman was like, yeah, that's not how her life works. If you want to be one, you can be one. So my sister says that I almost stopped her from being a naturopath because I claimed it too early. But luckily, someone told her she could be a naturopath, and so we went to school. We wound up being 3 years apart, but 2 grades apart. And then by the time we got to naturopathic school, we were 1 grade apart. So I graduated, and then my sister graduated, and we started a clinic together, almost from the get-go. And it's been over 20 years. So some big fights. Sometimes my mom has to be like, okay, you're having a business discussion and it's getting a little bit out of hand. So we need sometimes a tiebreaker, but it's been great. It's been great working with like a sister, working with a partner who has your back and can also, we talk about cases all the time. It is really nice to have that person you trust to talk about like really tricky cases and where to go with them and what order of operations. So it's been, I mean, I like my life. I like it a lot. I wouldn't change it. I don't really have any regrets, but that's my origin story and my up to date. And then we've just been blessed with getting patients who teach us. And so a lot of the times we get really smart patients who challenge us and teach us a lot about what their condition is because they're really smart, almost always smarter than we are. And they give us a lot of the pieces of the puzzle, and then we can kind of do our jobs to put those pieces in order of operations that makes most sense medically. And it's been an honor working with really complex cases where they're looking for help and they've been to 15, 20 doctors, and we get a little bit of momentum, we get a little bit of care, we get a little bit of answers, and it's been a nice process. And it's definitely something I can see myself doing until I'm very old. I like the primary care, the one-to-one, and the digging into a case and figuring it out.
Well,
Yeah.
that's amazing, Carissa, and it's an incredibly charming origin story. And as listeners would probably imagine, when you get both Doherty sisters on the stage together, it's very, very entertaining in a very good way. And yeah, and I really appreciate what you said there about, having the smart patients and learning from your patients. I had the same thing in my practice as well. And yeah, it's just such a, kind of collaborative effort because, of course, they're bringing their firsthand experience with their illness to the table, plus, things that they're like, I was reading about this or listening to this or whatever. And like, I think this stuff relates to me because like I'm living with all these symptoms and like this stuff resonates with me. And then, we as the clinicians bring to the table, like, oh yeah, we have like all this experience and we can tell you like, does the glutathione seem to make sense or does the mold make sense in this case or what are the labs? And like, yeah, it's just a beautiful synergy between, doctor and patient. And that's, yeah, wonderful that you're living that. It's wonderful. And I hope you don't retire for a long time as well, for selfish reasons, because I just love the continuing education that you and Sonia put on. And yeah, as I was saying before we started recording, for folks listening, there's a conference coming up in Toronto in a week from now in early May. And yeah, both of you are speaking, and I just can't wait to learn more from you. So it's going to be great. Um,
I'm glad you're coming. That's awesome.
Thank
I
you.
know we met like years ago, but it seems like it's forever ago.
Yeah, I know you've come out to Nova Scotia to speak a couple of times, and so yeah, glad to have a chance to go your way. And I mean, just yeah, to be frank, like the conference that's coming up, like I'm just really excited about it. Like I've been, talking to my residents and my colleagues and my wife, and just being like, oh my gosh, like there's actually a really, really exciting conference in Toronto. Like they don't have like really, really exciting ones that often. No offense to the other conferences, it's usually like I got to travel to, the States or out of the country. So anyways, very, very excited about it. So as our little sneak peek here, prior to learning what you docs are going to talk about next weekend, I have a few questions. Just before we jump into those questions, I forgot to mention in the intro that I recorded before we started chatting. Just as per usual, nothing that's discussed on the podcast should be construed as medical advice. This is for informational purposes only. If you need medical advice, please talk to your healthcare provider to get that advice. We generally don't talk about, dosages and things like that per se. I mean, if it's kind of appropriate to the conversation, we can get into it maybe a little bit, but definitely not giving any health advice, as everyone would know if you've been listening to the podcast. But if it's your first time, there's a little friendly reminder. So I have probably a million questions that I could ask you, Carissa, but maybe we can just start with just kind of like a general, like, what are some of the things that you've been finding to be most impactful in practice recently? Like just some, say supplements or herbs or treatment approaches, or I don't know, just what are some things that have been kind of a bit on the more, yeah, what are some of the more exciting things recently that have been helping some of your cases, or yeah, what comes to mind?
I'm pretty obsessed with salt these days.
Mm,
Not to the point where it's like excessive. Sometimes, sometimes the salt interest is pretty excessive because I feel like everyone who's calling now has POTS, or everyone who's calling is post-viral sequelae, like they're sick after having had a virus or sick after having something, and they're quite sick. Like I have some patients who are debilitated, and there is this trend of anaphylaxis that's coming in where the anaphylaxis is now taking over lives. Like I had a person who has an anaphylaxis just to anything. It's just wild. Like some of the cases are wild. I was going to get into details. I'm like, no, that person, you can actually identify the person with the weird details. um
mhm,
like maybe not. But there's an underlying allergy piece that's kind of coming to the surface, that's really scary. And I think the nice thing about our medicine is that it is gentle, it is safe, but a lot of the things that are happening now are complicated. Like I think there's a lot of multiple step pieces, and I think when we're looking at taking a case, if we look at it through one lens or one idea, we might not be able to look at the case and have an impact on these complex cases, or we're more likely to aggravate them. So a lot of the things we're trying to do with these complex cases is taking a multiple lens approach, where if we look at the microbiome, the digestive system, and we look at the mitochondria at the same time, or we look at the microbiome, the mitochondria system, the methylation system, and the inflammatory, like some of the inflammatory mechanisms. We look at maybe really gentle ideas, but that they encompass one, two, three, four all at the same time, instead of going one idea first and then one idea. I think these complex cases almost need like to pull from a couple different resources at the same time when you're trying to plan, and then kind of pick it up and go deeper and then pull it to the next protocol. Um, but they're wild. Like I see more POTS just because I'm pretty obsessed with it. So we see POTS that's like traditional POTS where a lot of young people, age 15 to age, 25, 35, are just not functional. They're either going to school, they're not going to school as efficiently as they want to. If they're working, that's all they're doing. You're not kind of excelling in life. And just exertion wipes them out. Um, so a lot of the times we put in really high salt doses, and sometimes it brings their life back. So the Dysautonomia Association or Dysautonomia International, they have like a conference every year, which is lovely, and it's online. You can go personally. Like it's in person this June in Chicago, but I'm probably going to do the online version. And it's nice because this is an association run by patients, and they actually are tapping the doctors and the physicians. They're saying, we're noticing this. Can you do research in this idea? It's one of the only kind of conditions that's being led by patients. And so some of the patient experiences is leading the research, which has never happened really before. Well, I guess it's not happened as aggressively. So some of the research is showing that some of these people that have POTS, which is postural orthostatic tachycardia, or my heart beats fast when I stand up, need crazy high amounts of salts, like crazy, like half a case of Gatorade to a full case of Gatorade equivalent salt a day, and it stabilizes them. Now, you won't do that on a regular basis and not have a benefit. You're not going to take half a case to a case of Gatorade over and over and over again and be like, it didn't work. Okay, then stop. Don't do that. But we're finding the dosing of salt has to be quite high for these patients for them to notice a benefit. And it's almost always missed. Once the people are diagnosed, they're never on enough salts. And so they're like, I did salt, and then they're on to the next idea. We have to kind of go back and say, you're not on any salt. You've got to be on much more to sort of say this is the max of this mechanism or this idea.
Yeah.
So
Oh, sorry.
yeah. No, no, go ahead. Yeah.
Sorry, yeah. The one disadvantage of me not being on the screen is there's no nonverbal cues that I can give. They're like, oh, he's going to say something. So yeah, apologies for not being visible right now. Yeah, I was just going to say, like, yeah, I've so many patients where, like a few years ago, I took Dr. Elena Guggenheim's course, like training course on this, and from there, I was like, oh my gosh, like I've been missing this like huge thing. And so many patients. So like it was almost not, I don't, not really comical because it's not funny to miss things in your patients, but like, okay, I've got like, at least like, 4 or 5 dozen patients that I need to call to say, so I think I know what's going on with you. And it's like some patients, like, I've treating them for like 10 years, like, getting results along the way was like, oh yeah, then the salt then fixed everything. It's like, oh boy. Yeah, so yeah, I have a love affair with salt as well. Um, I'm just yes, and as you were saying, many patients like where they have the POTS diagnosis and they're yeah, just like, oh yeah, I'm like putting some electrolyte powder in my water a few times a day. It's like, and so what about the rest of the salt? I'm just wondering, just in terms of troubleshooting tips, because with some patients, and I'd be curious to hear your input on this too. Some patients, it's kind of like I'm a little bit worried about them because they're like, like the salt, like the saltier it gets, like it kind of tastes sweet. Like I really kind of like it. And then and it's like, good, I'm really glad. And then like, the other half of the patients are like, I hate salt. I am not a saltwater dwelling fish. Like, yes, we're in Atlantic Canada here in Nova Scotia, but like, yeah, I cannot be just, it's too much salt. So, do you have any tips for folks where like they'll either get kind of nauseated from adding salt to their water or yeah, what are some troubleshooting tips for folks who don't love that super salty taste?
I think some of them have the gastroparesis piece. And so I just messed up a case like just last Friday where I gave something where I shouldn't have given something for a POTS patient, and he presented already with nausea and diagnosis of gastroparesis. And I made it way worse. And so I'm like, oh crap. So I think sometimes what happens is in some POTS cases, there's a winner. And if salt isn't going to be a winner, you sort of have to skip it and then go back to it. And so sometimes with POTS cases, you're going to have to skip to carnitine is another winner for some people. Carnitine is the bridge that puts energy into it puts fats into the mitochondria, but carnitine is also a carrier for neurotransmitters. And I find sometimes with the nausea piece, you're having to treat the gastroparesis, like the irritation in the stomach small intestine, like the lack of mobility and motility. So there's like an inflammatory aspect, but there's also a stasis aspect where we might have to support that system a little bit before we do the fact that there might be low blood volume. So if POTS is mechanism wise, if you have low blood, like so POTS is that when I go from lying down to standing up, my heart beats really fast and my heart rate goes up. And sometimes that's because you have low blood volume. So if you have low blood volume, but you really want normal blood volume, you could fake it with salt. You could pretend like, oh, I have normal blood volume by adding salt and water. But if that doesn't work or the salt doesn't go where we want it to go, sometimes there's other mechanisms you would have to push in. And sometimes those mechanisms would be carnitine. Sometimes those mechanisms, I'm always shocked when people feel better. And then I ask them, I'm like, well, what do you think? Like, what do you think did it? And I had one case and she was not functional. She was like in her early 20s, had to quit university, um, or she had to go part time. She had to go part time online, couldn't be in person. And then we had 4 or 5 visits, but it wasn't really working. So we kind of went on to different ideas. So, and then we did a call, and she had just come back from Thailand from a trip where she was on like riding elephants, and then she was going to BC for university. And so I said, well, looking back, what do you think was the game changer? And she was like, magnesium. Oh, okay. I didn't know that that was a significant piece that stabilized her biochemistry. But with the magnesium piece, sometimes you need to address the high adrenaline, the high heart rate. And if you can do something that breaks down the adrenaline to take some of the pressure off either the heart rate, like the high heart rate, the elevated adrenaline, or magnesium to support energy in the tissue in the villi. Like you just need a trick. You just need to weigh in. So with my POTS folks, oftentimes I'll do salt and cod liver oil, which is kind of gross, but the reason that we do cod liver oil, the liver of a cod is gross, and not just omega-3 or fish oil, is because it has vitamin A and it has omega-7 in it. And we're finding that the omega-7 is very anti-inflammatory for some cardiovascular inflammation. So if there's drama in the vascular system, like the arterial system or the venous system, and the people are young and strong, and you can't really tell because the blood work looks great, but obviously they're sick, they're unwell. Sometimes we put cod liver oil in because it talks to that system and it creates an ability to have less inflammation for a while, and that can be a win. And the carnitine and cod liver oil kind of go hand in hand because they're a fat story. Carnitine is the bridge that put fats in the cells, and then cod liver oil is an anti-inflammatory fat that can sometimes help. But sometimes there has to be other tricks. Like I do like beet crystals, and I find beet crystals will sometimes dilate the vascular system, more the arterial system with nitric oxide. And that can sometimes buy us some more leverage or some more wiggle room so people can feel better and then they can handle things better. So sometimes if you dilate the blood vessels a little bit, it buys you more time to have people strengthen. Um, so I think the POTS piece does have, and there's some correlation with PCOS. So we see a lot of young women who also have a comorbidity diagnosis. They also have pretty significant PCOS. So some women need a ton of inositol, some men too, but inositol is one of those things that also breaks down the adrenaline. So if you have a high heart rate and your heart is fine, but your heart's beating because of the adrenaline, inositol can cut up the adrenaline and clear it from the biochemistry. So some people are really inositol responders, and that will loop into a hormone dysregulation stability and an adrenaline stability, which is going to be more cardiovascular symptoms like shortness of breath and dizziness and heart palpitations and just feeling like you have no energy. When a person does have energy, they lack the vascular ability to get the energy to the brain when you want it there. I think the other little thing that we're working on, and I don't know where it falls in like order of operations, but excuse me, because COVID happened, we were doing a lot more work with zinc and quercetin and ECGC, because that was researched to have an ability to stabilize the immune system, but also sort of treat viruses. So we realized that some of the cases for POTS were almost like a Raynaud's, where the vascular system inside was swollen inside, almost like the arterial system inside was kind of closed a little bit, like an allergy response. And so quercetin as an anti-inflammatory was interesting. And then zinc requires a zinc bridge called an ionophore, a zinc ionophore, and herbs that are zinc ionophores are quercetin and ECGC, or the extract from green tea. So we found some tricks where we put in fairly significant doses of zinc, which are hard on like on a POTS person. They've got digestive, they're really sensitive. And zinc is often really hard on a raw stomach. But we found if you put zinc inside a quercetin, like comboed it together, they could handle it. And sometimes that anti-inflammatory benefit in the vascular system calmed down the vascular system, opened up the vessels, and allowed more blood flow without drama and without inflammation. And that was sometimes a win. So sometimes the quercetin kind of zinc combination was more for the Raynaud / histamine vascular stories. But usually there's a trick. Usually something's going to wiggle the case loose, but the POTS folks are tough. Like there could be a one-off visits that I'm seeing and I just don't see them again. So I don't know that they're done. Like when I did lots of fertility, I would see see pregnant ladies a lot, and the partners. And then sometimes I'd see the baby walking on the street. I'm like, you need to call me and tell me that it worked. Like that's like,
Mhm.
I'm gonna in my head think there's still a problem, but you have a little baby there. They're like, oh yeah, I should have given you a card. I'm like, I don't need a card. I just like, hey, to finish off the story, we're good. Because then I can go back and be like, oh, that idea or that mechanism is good for you. And then if I ever see you again, or if I see your baby, those ideas, we kind of think about those as future ideas. I haven't yelled at anyone, but it's so sometimes when you have a case, you don't know that they do really well because they don't come back. So you only know the cases that are tougher because they come back and they're tricky and they need those next steps, or they need, the protocol was theoretically right in your head, but like either it aggravated, which is interesting because sometimes that's the way you work a case through, not the nicest way to work a case. But if you can make someone worse, you typically learn about their biochemistry. Not the nicest way to do it. It's nicer to have them feel better, and that's the better way to work on or learn about their biochemistry. But usually with POTS folks, it takes like 4 to 6 visits to stabilize them, and a couple visits sometimes to learn about them. Sometimes there's just this last Friday, a week ago, I aggravated a guy on carnitine. And then I talked to Sonia about my sister about it. And she's like, you can't do that. Like, can't do that for a kid with gastroparesis. I'm like, but he was like 24. He was like strong. She's like, I would never start that with, I would never start a carnitine case, like a gastroparesis case with carnitine. Okay, well, I have to call him. Like, I have to call him and tell him that of the things that he took, he had a rough weekend and my fault. And this is why it happened. And then this is the plan going forward, which it's my responsibility. And it's why it's the art and practice of medicine. And I'm still practicing, still figuring things out. But usually aggravations are really helpful to work through, because they're almost always going to be one of the linchpins in a case. It's just not the nicest way to do it.
I think
I can't
it's
even, yeah.
oh, sorry.
I was gonna say I can't even remember your question now.
We've traveled around a little bit, but you're just like you have all this information inside Carissa, and I think you just need like a little like opening, and you're like, okay, here's like a ton of information. So keep it coming. No complaints on my end here. Um, um, yeah, and I think I couldn't agree more. Like, I think that's something that's not really talked about a whole, heck of a lot because it's like, oh yeah, listen, we're listening to podcasts or interviewing people about, complex chronic illness. It's like, patients flare all the time. It's just a fact of life when there are these challenging cases, especially when people are sensitive, when they have, histamine intolerance or mast cell activation syndrome issues or whatnot. It's like it happens. And but I think, and I've had this feedback from my patients. I certainly can't speak for all of them, but I've had the feedback where it's like, okay, I had a flare up. Well, this is probably why you flared up. And as you said, like, it gives us this incredibly valuable window of insight into their biochemistry, especially when the folks, like you were saying, they've seen however many doctors before seeing you. And then, one of the most important questions to ask is, what have you tried? And like, what made you better? What didn't help? What made you worse? And like, that's just a treasure trove. It's like, okay, oh, you flared from all of these, like things that can, whatever disrupt biofilms or something. Okay, there's probably something like that going on there. So, anyways, yeah, very, very well put on your part. Um, I
It's scary though. It's scary as a practitioner. Yeah.
Yeah, and can be scary for the patient too, especially when they have those really, extreme reactions. Like I've kind of been I don't even when I have like the occasional, as I affectionately call them, like, normie that comes into my practice where it's like, oh, you just have like headaches and the rest of your life's not falling apart at the seams. Like, oh, okay. That's nice for you. Um, like with everyone, I'll just like, we're just gonna start low and gradually build up. It's like, why? Well, just in case, yeah, that's I think the only defense to a flare up is like, well, if you're gonna flare, hopefully it's just gonna be a mild flare and short-lived, and hopefully we can just go slow. But yeah, it's a process. I have a couple more POTS related questions for you, Carissa. I figured we'd talk about this. I think this may just be the POTS episode, and hopefully, if you don't mind chatting with me again sometime, and we'll chat about other things too. We could probably fill about a dozen episodes. We'll just do like the Carissa Doherty series, at some point over the course of time. Um, but I
I
was
can hear
just wondering.
myself talk.
Good. Yeah, good. That's why I wanted to interview to hear you talk. Um, so when patients come in and they have that, whether they have a pre-existing POTS diagnosis or, you identify POTS and then, they'll go off and say work, at least I know in these parts here in Nova Scotia, it's like, okay, you have to get to see a cardiologist, or, going to like we have our version of the sick kids hospital here, like the IWK. It's if they're under the age of 18, they go there to get worked up. But for patients with POTS, just what you've observed in your practice, which medications, like pharmaceutical medications, if they need to go there, not everybody does, of course, but when patients do work with pharmaceuticals for POTS, which ones do you find, or which classes of those drugs do you find to be the most helpful? Like I know here around here, it's usually like the first thing is like try some salt. As you said, not always enough salt, but that's usually what they'll try first. And then, beta blocker is almost always the first medication that's recommended. And then if that's not working, then maybe they'll move on to something like Mestinon or, other drugs. I'm just wondering which pharmaceuticals you've seen kind of move the needle the most or the least, whatever you want to comment on there, please.
I think it's probably the beta blockers. I think the beta blockers for my folks will move the case a little bit, and then it allows the practitioner, like the medical doctor, to then go in and do others. And so I think if the patient doesn't move on beta blockers, sometimes the practitioner in Ontario will give up and be like, okay, we can't go further. But if the patient gets a little bit better on beta blockers, they can go down the cascade. And so I I'm forgetting all my drug names now. I'm forgetting them all. I'll have to put a pin in it, because I think when I hear that, I'll tell you what I think. When I hear that the person is doing better on the pharmacology, whether it's the vasodilators or having the adrenergic system controlled, the adrenaline controlled, or pulling some fluid from the body, I think that it's great, and it can be game changing. It can definitely like stabilize a case, which is great, but it doesn't move the case. It doesn't cure them. And so we're looking for a different mechanism. So I will advise the patient, like, here's the drug classes. Could you ask your doctor for these drug classes? And I kind of give them a summary. It's not that I don't care about the summary. It's just I forget about them, because I'm like, you need to do this for quality of life, but that's not my job. My job is to see if we can move the needle of care so the biochemistry of your system is strong, so that if the medication does help, great, but they can't get off them then. So if you have drug responders, it's great, but they're stuck there for years and they can't move off of them. And then they come to see us. And so anytime we can move the needle while they're on the medications that stabilize them, great. But I don't even think it's yes, I do give them the summary so that they can have nice conversations with their medical doctor, so that it's simple, and we can put the word POTS in the ear and make it very medical, so that the patient doesn't get diagnosed with an anxiety disorder or a psychosomatic disorder, because it's very medical, it's very real. So I give them enough to get the doctor to buy in without, like, the naturopath says I have this. And so it's sometimes can be offensive, and we're weird, like that voodoo medicine person thinks that you need to hold crystals and there's a pots and pans going on. But I don't kind of go into like, take this medicine, take this medicine, take this medicine, just because a lot of times in Ontario, the doctors are not, they're not going to do it. And so the more I interfere, the less my patient gets. So I do initiate a conversation. I do initiate like a summary, and then I leave it. And then it winds up being the patient who can dig in and then be like, I need this drug. I need this drug class. I need this drug class. And I kind of don't pay attention to it. I know that's awful. Just because I don't think it's my skill set. And so oftentimes when I get the patients, they'll already have tried all of the classes and they'll have stabilized on none, one, four, three, and they'll be as stable as they can possibly get, because there's not really another drug class to do. I know I'm not being very helpful, but I'm like not answering your question.
No, no, that's answering the question. No, just want to know for your clinical experience. That's why when I approach guests for the podcast, it's like you don't have to do any prep for this. Like I just want to hear like what you're seeing clinically, and like that's beautiful. That's great. I
I
have
just I use like the pulse oximeter.
oh
I find that with the POTS, what we're also looking at is like the O2 piece. So like I can spell backwards, right, when I put it up there.
uh
But with your
mm,
with
I,
your with your O2 and your heart rate, it's all off. I find sometimes what we're seeing now with the POTS is that the heart rate is wild, but also the O2 is wild. So lots of people are using their like, their smartwatches or their whatever's to correlate this. But sometimes in the office when we do it, or I get them to buy the pulse oximeter,
mhm,
because I have like a $3,000 one, which is great. But I find it's just as good as kind of the $20, $50, $100 one.
mhm,
Um, that if we don't watch the O2, sometimes that's a case. Like sometimes the oxygen is one part of the story, and then the heart rate is the other part of the story. And some people are very classic where their O2 is amazing. So you want your O2 saturation to be 97 to 100. It's not an option. You can't have a B in this story. You have to have an A++. It has to be 97, 98, 99, 100. Not an option. And there can be some error, right? Like if there's bad circulation or there's whatever. But really, you do want to see your O2 be very stable on the positional change. So oftentimes I'll say, could you get a resting heart rate, maybe outside of this office when I'm not talking really fast and stressing you out? But at home, lying down in bed in the morning before you get up out of bed, what is your true resting heart rate? I just, I say like your heart is a muscle, and the more physically active or the younger you are, as long as you're an adult, your heart is going to beat slower, because your nice strong heart is a muscle that beats slower depending on how much time you put into that muscle. And so if your true resting heart rate, of a previous dancer is going to be lying down 95, that's weird because this dancer would have put in hours for their heart. And so their heart rate, like a 21-year-old dancer, ex-dancer, their heart rate should be 45 to 55. Doesn't matter if they haven't danced for a couple of years. They're an athlete, and their heart is going to have muscle memory that's going to need to respect or respond in kind, or like it's got to look the same. So sometimes you've got like a POTS like case and they don't have the standard. So then I could say later on in the day, could you then take your heart rate in the order of seated, lying down, standing? And the traditional diagnosis for POTS is when you go from lying down to standing, your heart rate should go up 10, 15 points. That's normal. You want your blood to go to the brain, and then you want it to sort of like your heart rate to go down to a regular resting heart rate after a couple of minutes, no more than kind of 10. You want it to come down because you don't want your heart to just beat fast just because you're standing up. That's not a great compensation for living. Your heart should be able to, like, I got a fresh little volt of blood to the head, and now I can keep the flow going. So that's a normal reaction when you stand up. You don't want your O2 to go down just because you stood up. And when we get some numbers that are pretty stable, sometimes then I'll get the patient to talk. So then I'll be like, can you just say the alphabet out loud for me while they're standing? And then sometimes their O2 goes down when they're talking. So O2 is an automatic or an autonomic system. You shouldn't have to control your O2. You don't think about your breathing. I could probably breathe now, but it's something that is your right. You're supposed to have O2 in your head and your fingertip all the time at 97, and just standing up shouldn't require you to have a loss of O2. So sometimes that's happening, is there's an O2 dip on standing or an O2 dip on talking while standing. Or the O2 or the heart rate doesn't go down like it should, or the heart rate doesn't even go. So I think there's POTS, right? And then there's like these subcategories which are now actually diagnosed, and I'll I'll present them all next week. My presentation is not quite done, but I'm writing down all the things I have to present now,
Mhm.
now that I'm talking about it. Um,
Good.
but there's subcategories, and although we might not call them POTS, sometimes the symptoms the patient is experiencing would be like the heart rate doesn't go up when you stand up. You're at a heart rate of 70, and then you stand up and the heart rate kind of stays at 70. Like, well, that's not right. You will need blood to go to the brain, and instead it's just going to the feet or something.
Mm.
Um, so sometimes even this simple kind of little test in your office could give a significant amount of information, not necessarily to the cardiovascular system, but the vascular system and the adrenal system, and sometimes the cardiovascular system, depending on where your patient is, age, symptoms, blood work, kind of where they put in it. So this guy, yeah, I kind of got obsessed with the pulse oximeter in the last couple of years.
Yeah, that's really interesting, and yeah, I have not heard of that. So I'm looking forward to hearing it in the really official sense with the lecture
Oh,
next.
okay, then I'll put that in. I'm gonna remember.
Oh, please do. Yeah, yeah. Because I
Okay.
mean, I haven't heard. I mean, I now actively seek out CE related continuing education for folks for on POTS and other types of dysautonomia, and I have not heard anyone talk about that. So, yeah,
Okay.
please do.
Okay.
And then write a book on it, and that'll be your claim to fame. Everybody needs a shtick. So,
I bought a couple books on POTS, and I'm like, it's not even mentioning this stuff. I'm obsessed. I'm a bit obsessed. I think I get it now when Sonia got obsessed with autism. My
mhm,
sister got obsessed with autism. I'm like, eh. And so now I'm like, oh, I get it. I
there we
get
go.
it. I,
Yep.
I see the world all in this silly, silly idea.
Mhm.
Um,
One question I have for you, and
yeah.
I think maybe I'm missing something here, so just please correct me, and we'll move on to something else. But I think you were saying that some patients with POTS, they will have these oxygen dips with their pulse ox, and so if that's kind of like we'll say a subcategory that they fit into, if like okay, you've got POTS and this like lower oxygen saturation, are there different treatments that you would use or like therapeutics that would be more effective for folks who have that oxygen dipping happening versus those who maybe quote unquote, just have the elevated heart rate, but they're not having a oxygen dip?
Can I show like a supplement?
Sure. Yeah. There's
Okay.
no, this isn't like CME
Okay.
accredited.
Okay.
So
I'm
yeah,
like, is there?
put whatever you want in here.
So I made like a botanical. It's all backwards. It's like, I don't know why I'm showing it. So I made a botanical, and it has so there's different mechanisms for POTS. So sometimes when you're looking at microcirculation, you put in things like ginkgo and European blueberry. Um, but I wonder if things like hawthorn are really interesting in some people. Hawthorn is a herb that kind of tones the cardiovascular system. And it's like you can use it in anything. You can use it in hypertension, you can use it in hypotension, you can use it in heart block, you can use it in arteriosclerosis. It's just one of those herbs that's really nice to tone the vascular system. Um, so I am sometimes using more licorice to increase blood pressure in those that have low blood pressure, but we can't do that with people that have high blood pressure because that's a subcategory. Um, and then sometimes we're using valerian as an adrenergic stopper. And valerian has been game changing for some cases because it's the adrenaline. It's adrenaline that is the guy that is tanking the system. So sometimes what we do is we do a short shutdown protocol where we give someone the option of taking valerian either in a liquid or in a capsule in the morning, in the afternoon, in the evening, and do that aggressively, go, go, go for 2 weeks. And if you can get off the adrenergic pathway by getting a herb that is an adrenergic blocker, it's not, it won't stay in the body for a long time. It will only stay in the body for a couple hours. But if you tell the body, like, stop going into fight or flight, stop going to fight or flight, stop going to fight or flight, over and over and over, sometimes the body's like, maybe I'm not going to go into fight or flight. And then the elevated heart rate that happens with adrenaline can sometimes be very much controlled. So in some cases with the O2, it's about the adrenaline. And it's almost like I don't know the mechanism. Okay, I have a theory with the mechanism. It's so boring. Okay,
Lay it on us, please.
okay. So I have a theory that the adrenaline is causing how do I had this great video and explained it so well. And so respiratory alkalosis and respiratory acidosis,
Mhm.
so boring. Okay, so adrenaline will take O2 out of the tissue because um, adrenaline will induce respiratory alkalosis. And then the body, the blood vessels, the lungs will have to do a respiratory alkalosis to compensate. So what actually winds up happening is you get your blood, lots of adrenaline will cause a bicarbonate in the system. And so you actually have too much bicarbonate in your blood. And so one of the only ways to do it is to slowly breathe the bicarbonate out, or the base out of the system. It's really hard to do that when you're in fight or flight. So sometimes it's not really about like the adrenaline in the system, it's the corresponding reaction for the body, which is to flood it with a base to compensate. It's why respiratory acidosis and respiratory alkalosis have no treatment. There's no medical treatment for them, which is weird. So I think POTS actually has a part to play with respiratory acidosis and respiratory alkalosis. I'm not explaining it well, but I think valerian hits it so that it stabilizes the O2 that's stuck in the vascular system and allows you to like interrupt it and breathe it out. So it's more like a concentration problem with bicarbonate.
Hmm.
Okay, that's the worst explanation ever, but I'll send you the video. It made sense, and I was like, oh, this explains acid base biochemistry so well because it's so boring and it's like it's so important. And then when you look it up, you're like, it's boring. I'm doing a bad job. I will do a better job. I'll do a better job at the thing.
I think the punchline's exciting anyways, where it's like, oh, like calm down the adrenaline and things get better, you know? So like the punchline is exciting, I think.
I think the calm down piece I thought was about adrenaline, and I think it's actually about relieving the pressure of a base that's stuck in your blood. It's
Hmm.
actually about the bicarbonate leaving,
Right.
which seems boring. I'm like, can't you just do baking soda somehow?
The problem in
Um,
the first place though is too much adrenaline,
mhm,
which is how the valerian would help,
mhm,
but it's then leading to acid base imbalance.
mhm.
Yep. So that's exciting for some of us. And then, but for everybody, I think it's just exciting, like, oh, like there's a solution that makes things better. But yeah, and then there's people like us who are like, oh, we like the boring stuff. So everybody's
So
happy.
that so that's the O2 piece. The
Yeah,
O2 is that the respiratory alkalosis is displacing the O2. The bicarbonate is like you're taking all the O2 and you're making something else with it, and so it's not there for you to use.
right.
Yeah.
Okay.
So valerian, we call it sweet garbage because it smells like sweet garbage. It's like,
We brew our own tinctures at our clinic. We've been doing that for years because it just really knocks down the price point for patients. We won't brew valerian though. We still order that from, St. Francis or whoever because we're like It just destroyed the clinic once. We had to air it out for many hours. So yeah, it's yeah,
I,
the sweet
I mean,
garbage smell. It really lingered for a while.
we have great staff. I think they're gone for the day, but we have great staff, and we use Valerian all the time personally, like because we have tough cases and they're stressful.
Hmm.
And I think this thing with, and like tough cases get sick and then they slam the front, which they should because we are helping them, but also, you know, it's hard when you're sick and the front staff are taking the hit for it. So we actually drink a lot of valerian in the clinic ourselves. Like we have shots of valerian
Hmm.
because they work. And so there's more than one episode time where we've spilled the valerian and our staff is like, okay.
Oops.
And we're like, I'm so sorry. They're like, it's okay. It's just they're like saints. We're just like, "Ah." And anyway, there's got to be grown-ups in the room and they're not us.
Yep, that's why you pay people to be the grown-ups in the clinic. Yeah, we do the same thing at our clinic.
Yep. Yep.
Are you going to be talking about valerian next weekend?
Yeah,
Okay,
if you
great.
tell me to. Okay.
Well, please
Put
do.
it.
Otherwise, I'd pick your brain about the dosing after we stop the recording. But because I mean, valerian, like, yeah, I usually just dose it at nighttime. But yeah, daytime dosing, that's pretty cool. Okay.
Yeah. So, I mean, it's we usually do just the regular companies that you can get, and we usually 2 caps twice a day. So it's like 500 milligrams
Mm.
3 times a day, TID,
Oh,
for 2 weeks. But usually the patients will know within days. And I've had a ton of people be like, I can drive now. Like
mm,
the, episodic, like I'm good, and then I go to drive a car and I'm screwed. Like now the heart rate, like the episodal anxiety piece.
mhm,
So we use a lot of the valerian for that as a first aid, and it's awesome because it's not a sedative; it's an anxiolytic. So in the herb family, with the adrenal glands, we've got like the inner triangle and the outer triangle. The adrenal glands in the inner triangle has adrenaline that it produces, and the outer triangle is cortisol. Cortisol is the boss of the day. Too much is bad, too little is bad. But you can't have two bosses. You can't be in fight or flight. You can. I mean, that's the people with POTS is they're trying to manage both bosses. They're trying to function on a daily basis while adrenaline is driving the bus of the biochemistry of the system. And so, as a herb, there's herbs that are famous for adaptogens where they help cortisol, be higher or lower. And then there's herbs that are anxiolytics, and that valerian's an anxiolytic herb. Anxiety is adrenaline, oftentimes. And so if you take a herb that's an anxiolytic, it's not a sedative. So one of the ways you know that this is a nice hustle is that if you give them an anxiolytic and they're tired because they're stuck in there, you just took away their fight or flight, and without it, they won't survive normally, which is fine. They will slowly stabilize and they'll slowly try to switch their boss system to the instead of fight or flight to the cortisol as the main boss for the day. And valerian is a really nice stable guy that can just train you from being stuck in fight or flight to being back to where your go-to is.
mm.
We just say fake it till you make it. Pretend like you're not in fight or flight until you're actually not in fight or flight.
I'm just wondering, like, kind of in contrast, like just clinically, like in contrast to say, like a liposomal GABA or like a lemon balm or a motherwort or a California poppy, like, just kind of clinically, like, how would you choose valerian over one of those other agents? Like, what would the some of the clinical features be or clues to say, like, let's give that a try instead of like
There's
one of those other guys?
how anxious you are with a person who has anxiety. Like, honestly, these people are really sick, not sick, but they're really uptight. And the more anxious you feel, the more that it's adrenaline based versus because GABA is very calming. And a lot of the herbs you mentioned are GABAergic, which is nice, But if GABA is not the guy to calm, like, and GABA is going to play referee between serotonin and dopamine and adrenaline, and it's a great. Your GABA when your brain is irritated and inflamed, it makes glutamate, which is irritating and bad for the brain when it's in high concentrations. And glutamate will convert into GABA. Like you can actually clear your brain biochemistry sometimes with that idea, that hustle with elevated glutamate, which is bad, GABA, which is good. And so the conversion of that is dependent on B6 and NAC. So we don't do a lot of GABA herbs in the clinic. We'll do more B6 NAC. And if a person feels better, we know their brain glutamate's too high, and their production of GABA is what's happening when they feel better with the way those ideas. Or if they feel better with GABAergic herbs, then maybe their glutamate is too high, and we know they're stuck in the IDO1 pathway, which is where you make glutamate, and then we tend to do the restrictive diet piece. So that's an IDEO one pathway hustle that I will leave to Sonia because that's one of her main hustles. That's why we got a free trip to Beijing. Sonia talked to the a conference on Alzheimer's, and she's like, I'm a naturopath who sees little boys under 10. But I do know the IDEO one pathway, which is what I'll tell you about. So I'll leave that piece to her because if I take all her things, she's gonna yell at me. And I sort of want to do it because it's hilarious, but I'll leave the IDEO one pathway for her. So that story that I just told, she
Yeah.
does it way better too.
Okay. We
Way
we don't
better.
want to we don't want your mom to have to, referee too much more than she already does have to.
Oh my
So
goodness.
yeah, yeah.
I think she's already had to do one this year. No, it's been years.
Yeah,
The
I think.
other piece I wanted, yeah, go ahead.
Oh no, please go ahead.
One more thing I want to say is that my we have someone in our family who has a ridiculous wild asthma, and the presentation was very not classical, but we actually have like O2 in my office. It's my garbage in the O2 tanks for him because his O2 can tank so quickly, and it was POTS. So Salt brought his O2, which
Wow.
was always at 92,
Hmm.
to 98, which he hadn't had a regular O2 for years, like for
Wow.
years. So the presentation for some kids is or adults is actually asthma.
Wow. That's wild. So like there was no like elevated heart rate or anything like that that was obvious. It was
Well, he's on puffers.
mm, right, right. So
So
asking.
yeah, like we thought his heart rate was elevated because he's on adrenergic puff, like he's on puffers. And and then yeah, it was wild. And I think that asthma, allergy, eczema piece is gonna be a bigger deal with POTS in the next couple of years because it feels like tons of people have it. I'm sure you see it in your. Is it just me, or is it you're seeing it too, right?
Lots. Yeah, way more
Okay.
than I ever thought would be applicable. Like back in the day, I was like, oh,
Yeah.
that's just kind of a rare thing you see from time to time. And yeah, just all the time now. It's yeah,
Yeah.
high up on the radar.
Yeah.
Um, Carissa, I think we might need to do a part two pots because like I'm like, I still have a bunch of questions, but I know we're over the time that we had pre-agreed upon, and I know I hear my wife making dinner downstairs, and yeah, I know I'm sure you have other things to get to as well, but thank you so much for taking the time to chat with me today. Just before we wrap things up here, could you just let listeners know just your clinic website, if there's any social media opportunities, and also too, if as I do know there are quite a number of listeners like naturopathic students or other, fellow colleagues or other clinicians. So I know you, well, from firsthand experience, I know that you have wonderful CE opportunities too. So if you don't mind just sharing those, and then I'll put them in the show notes, please and thanks.
Awesome. So we have a clinic called the Natural Care Clinic, and it's in Burlington. And we have 4 naturopaths here. We're kind of small. We're just like 1,000 square feet, and so we're just just have general patients. We do also, I mean, we'll see how we do sometimes take ND consults, and so at this point we're not charging. So if it is something you want information on, you're welcome to call us because we have a couple tricks, and so we just want to share that. We also have an educational platform called Exceptional ND for naturopathic doctors. We actually have an exceptional intern for naturopathic students that is free, and then the exceptional ND is not so free. But we really enjoy it, and it keeps Sonia and I busy. But it also, when you have something that's called exceptional ND, it kind of makes you research because you put the stupid name in the title. What we meant was that we strive to be exceptional, but
Mhm.
then the night before a presentation, you're like, it's gotta be
It has to be
exceptional.
exceptional.
Why did I name it this?
Mhm.
So yeah, that those are our
Mhm.
two things, and we're pretty easy to find on socials.
Okay.
I don't remember all the codes, but they're pretty findable.
Okay.
But
Is it under Natural Care Clinic or is it under your individual names?
all yeah, they're two separate. So Exceptional ND has its own thing on
Okay.
socials, and then Natural Care Clinic has its own thing on socials.
Okay. And is Instagram the main medium, or is there other
I think we have Facebook and Instagram. I don't think we have Twitter. I
okay.
think we do have Twitter, but it's not that active. But I think Instagram and Facebook are there. Yes, for both.
Gotcha. Okay. And just to clarify, as much as Exceptional ND is not free, it is everything's really well priced. So you're like, it's not so free. It's like kind of implies it's expensive. It's very well priced. CE, just to say again, as a
Yep.
customer, very
Thank
very
you. And you
fairly
can quit
priced.
at any time.
There we go. There we go. Um, All right. Well, again, thank you so much for your time today, Dr. Doherty. I really appreciate it. And I can't wait to see you in Sonia next weekend. And yeah, and if you're up for another chat down the road on the podcast, really appreciate having the chance to pick your brain again.
You too. Thank you. It was wonderful. And I look forward to seeing you next week. Thank you.
Great. Thanks. And thanks so much, everyone, for listening to this episode of the Overcoming Chronic Illness podcast. We hope you enjoyed it. And please stay tuned for the next one.